If her total testosterone is below 50 and she has a lot of symptoms, I will start her on testosterone around 50 milligrams. It will vary from patient to patient.
With your clinical experience, you've already gained mileage and have a good sense of how things will go. That's what you said, right? If it's decreasing, you have the tools to stop it. If it's aromatizing, it's the same thing.
And I'm very cautious with hormone therapy.
Hello, everyone. Welcome to another interview, another podcast from Saúde. And today we have the pleasure of welcoming none other than Dr. Tatiane Nacif. You, as a woman who is already over 35, 40, 45, are in the climacteric, full of symptoms, those hot flashes, right? You suffer from polycystic ovary syndrome, endometriosis. Today we're going to talk about women's health with her, who is a specialist. She is an obstetrician and she has studied at Syrio-Libanese, that's right. So if you're a woman, if you're suffering from these problems, you won't suffer anymore. Because today we're going to clear up all your doubts about women's health. We're going to talk about hormones. We're going to talk about supplements. We're going to talk about a lot of things. So stay here with us. And I want to give a warm welcome to my dear friend Tatiane Nacif. Thank you so much for being here on Saúde. It's a pleasure to have you here, and I'd like you to introduce yourself. Did I miss anything? Did I leave anything out? Say hi to our audience.
Hello, Saúde audience. My name is Tatiane Nacif, as Moacir introduced me. I'm a gynecologist and a former obstetrician.
Former obstetrician.
Former practitioner.
He doesn't deliver babies anymore.
I don't do that anymore. I help women get pregnant because, after all, we work with hormone therapy. But in 2022, I gave up obstetrics because I really needed to dive head first into this world of women 35, 40 and older, which is an extremely complex world where we don't have so many professionals in Brazil qualified for this kind of care. So I say that I gave up a great passion, but to live another one that, for me, brings me a lot of fulfillment. You introduced me very well.
Oh, good.
I really did those specializations. We never stop. You know that.
Studying every day. We'll talk about that. That's important.
Yeah, because medicine, health, technological advances, they don't stop, and we can't stop either.
I think that's true for all fields, right?
Yes.
Today, it's in every field. Marketing with AI, now artificial intelligence. Whoever doesn't pay attention is going to be left behind, you know? That's important. Well, my friends, right? Because today's episode is dedicated to my friends over 40. Our audience, Tatiana, is an audience of 35 and up, right? 70% of our audience is women, and most are between 35 and 55 years old.
Yes.
We have this data on social media, both on YouTube and Instagram. So are you among your audience here today?
Wonderful. And I joke that the female audience is the audience of goddesses. That's what I call them.
The goddesses, she calls her patients goddesses. Hello, goddesses.
Hi, goddesses.
We're going to share Tatiane's Instagram, okay? She's seeing patients in Sao Paulo.
Yes.
Does she see patients in Beverly Hills too?
No.
But she'll be seeing patients there soon, okay?
Who knows?
She has appointments in Sao Paulo. We'll give you all the contact information at the end. That's why it's important for you to stay until the end. So, we're going to talk about all of that, my friends, all the problems that affect women. Hormone therapy. Should you do it, not do it? Is it dangerous? Is it not, right? Is injectable supplementation worth it? Oral supplementation, we're going to talk about all of that. But first, before that, great, let's begin. You can place it in the corner. Let's start our chat, which is what matters, which is what everyone is here to listen to, our conversation. And I wanted to start, Tatiane, I always like to start with my guests with this reflection. I used to observe, I graduated in the 90s, right? Wow, it's been a while. And I noticed that all the training for health professionals was focused on treating the disease. And sometimes even worse, treating just the symptom, right? So people would go to the doctor because they were in pain, or because they already had diabetes, or because they had high blood pressure. In your case, right, they already had osteoporosis, right? Good point. Polycystic ovary syndrome, severe endometriosis, already a series of problems. And then you would go to the doctor to treat the disease, or even worse, just the symptom, right? And it was standard practice, and professionals were taught to do the treatment that I call conventional Western treatment. I don't know if that's changed, okay? You tell me. You're much younger. Has that changed? Is it different today, or was it like that when you graduated? And that was the guidance for health professionals. You have to treat the disease, forget about the patient, right? And then I noticed from about 5, maybe 10 years ago until now, I started to see some people shifting this logic, this idea. Several health professionals, and I noticed you making this shift too, realizing that the most important thing is not to get sick. Did this happen to you? Did you have this more Western training and then have an awakening at some point? Or have you always had this orientation? How was this? Getting into this more preventive, more health focused approach, because that's important. Developing health, not just treating disease.
Yes, I love the way you put it because that's really basically what's been happening, right? The feeling I have is that sometimes I left a traditional environment,
And that's how it was, right?
that it was like that it was an absolute truth and unquestionable, and to open my horizons to the possibility of treating my patient and preventing diseases from happening. So, when did that happen, right? When was my awakening? It wasn't during my medical training during college. I started to open my eyes to this when I was finishing my specialization. Right there at the end of my residency, that's when I started to realize that I was only treating the patient. But can't I prevent that woman from developing this disease? You gave the example of polycystic ovary. Okay, let's treat the symptom of the ovary, but isn't it much better if I prevent it from happening? How do I do this prevention? By promoting health, encouraging women, who are my audience, for example, to practice healthy habits. And then we have a range of possibilities: proper supplementation, physical activity, thinking about your diet, what you're consuming. We use a phrase like this, and I don't even know who the author is, but it's unpack less and peel more.
Peel more. Many people use it, but no one knows who invented it.
Who it is, we can add it.
Plant animal, right?
That's right.
Focus on animals and plants.
Exactly. So I see that this awakening happened to me at the end of my specialization when I was finishing my medical residency. And during my residency, I met other colleagues who were also on that path. I said, no, I want to be with these people, with this group, because I identify with this way of treating, with this way of prevention. And there are some terms that we use, for example, integrative medicine.
Yeah, and it's not really correct, right?
Yeah.
But it also creates a division, right? It creates polarization. Like one type of medicine is one thing and the other is something else. And that's not how it is.
But people have liked this term in popular use. But what do we use more, right? Even to, oh, what kind of gynecologist are you? Traditional? No, I practice personalized gynecology. I see my patient. She isn't just a woman, she's not like all the others. Each patient has her own particularities, so we say it's personalized medicine, okay?
Ah, interesting term.
Yeah, it's something we've been using more. And then, Moacir, from the moment you enter this world, you know this too. You become enchanted, amazed, right, with what you can provide for your patient. So, for example, today we have genetic tests to study that woman's genome and predict if she has any chance. For example, in my case, I have a family history of Alzheimer's. It was interesting for me to know if I have the gene for Alzheimer's. I have the gene. Does that mean this gene will manifest?
No, honestly.
But I can, through this preventive approach, avoid that dormant gene from waking up.
Epigenomics, right?
Epigenomics. So these are the possibilities that fascinate us. I'm much happier today doing this for my patients, providing prevention strategies and tools rather than simply saying, oh, you have disease X, I'll give you medicine Y. But what about prevention?
Yeah, because once you have Alzheimer's, first of all, the treatments today are pretty limited, right? After the substantia nigra has been affected, it's very limited and becomes progressive. You gave a good example, by the way. Chris Hemsworth, the actor who plays Thor, he found out that he has the Alzheimer's gene. He found out and did the mapping. I don't know why. I think he was going to do an ad for one of those companies and found out he had this gene. And he slowed down his career.
Yeah, that's wonderful.
He slowed down.
In my nutrigenetic test, look at the irony of fate. My main focus is treating women in the climacteric stage of menopause. In my epigenetic test, it showed that I have a 95% chance of having early menopause. What can I do today with this information?
Perfect.
I'm going to intensify my physical activity to reduce what we call oxidative stress. I'm going to reduce my alcohol consumption.
Reduce inflammation in the gut.
Reduce inflammation in the gut. So, look how beautiful this is. I think this kind of preventive care is fantastic. Actually, I have a group of doctor friends and we work along these same lines. And one of these friends of mine has 2 little daughters. She said, look, the greatest gift I could give my daughters, even in early childhood, was this genetic test. Because through it, I can already establish health practices, which is much easier in childhood. It's easier to teach someone to eat better, not to drink soda in childhood, than after it has already become a habit. So I thought it was really cool that she mentioned that the gift she gave her daughters was
I've already done it. How is it here in Brazil? You were only doing it in the United States. Are you doing it?
we do it, it's a procedure.
It's really cool, guys. It's like this. I still don't think it's cheap, but when it was in the United States, it was a fortune, right? It was really expensive. The price must have dropped.
Yes, when you think that you're going to have a genetic mapping, which is something that
How much suffering you're going to save, sometimes even on medication, even on expensive treatments, aggressive surgery.
and the procedure is super simple. It's done in the doctor's office. There are several types of tests. The test I took was the saliva test. So we go in
Previously, you had to send your saliva to the United States.
to the United States, yes. So we do it right in the doctor's office. It's painless. There's another test as well, which is the metabolomics test, where it evaluates intestinal health. And it checks how
Ah, that's amazing. This is extremely important.
super
And check the bios, see how the liquid is.
everything. If you have, for example, an allergy, I'm using less technical terms for those who are watching.
Yeah, perfect. I thank you for that actually, because sometimes I go overboard.
So, for example, the metabolomics test, what is it? It evaluates how your body, when you ingest some food or some substance, for example, when I take these supplements, what do they become inside my body? When I take a B complex, does all of it go to my cells and give me immunity? Will it have the result I expect? So the metabolomics test can evaluate what the response is,
This is fundamental.
how your body interprets what you are consuming. And why is it interesting to talk about this? There are allergies, right? Psoriasis is a type of allergy and autoimmune disease, right? Other skin diseases. We know that the cause is behind the body, that it's not able to metabolize what it's consuming. So the metabolomics test, I say that it's the screening to explain how your gut is doing.
The gut says it all.
Everything.
You gave a great example for everyone listening to understand. If you have a dysbiotic gut, what is a dysbiotic gut? It's your flora, which are the little organisms. The bacteria that are there aren't so good. Bacteria are important. Bifidobacteria, lactobacillus. There are a number of strains there. If it's dysbiotic, it means there are bacteria that aren't so healthy. And look at what's happening today. A case of depression. In a case of depression, you go to the psychologist, and invariably he will give you a serotonin reuptake inhibitor, an antidepressant, right? To reuptake serotonin. But 90% of serotonin is produced in the gut. Then you have this problem, which this test detect a dysbiosis. Then you take this here, tryptophan. There's tryptophan here, right? Melatonin with tryptophan. The tryptophan you take, depending on the dysbiosis, it should normally be converted into 5-hydroxytryptophan into serotonin, then into melatonin, basically serotonin. It can be converted not into 5-hydroxytryptophan, but into kynureninic acid, which is neurotoxic. So look at the size of the problem, which starts right there in the gut.
I had a similar patient in my office.
Really? Depression because of dysbiosis?
Yeah, that's right. It's really beautiful when we understand it, isn't it, right?
And what's the point of giving this person a serotonin reuptake inhibitor? Then you switch to a tricyclic. It's not working, switch to a tricyclic.
And this part about the gut is so interesting because, for example, women who do hormone replacement and have intestinal dysbiosis, they don't absorb the hormone, or maybe they do absorb it, but it's all excreted. And then it messes up your gut flora even more. So if the patient isn't,
Magnesium often causes diarrhea.
if her gut flora isn't all balanced, right? The strains, as you mentioned yourself, no result, no treatment will have the effect we expect. I tell my patients it's just as important as doing proper hormone replacement. It's about having your gut working properly because otherwise you won't benefit, you won't get the expected response from this treatment.
And picking up on this hormonal topic, because I know a lot of people listening to us here want to know about hormones, right? Women want hormones, men want hormones, everyone wants hormones. It seems like hormones are the solution to everything, right? It will solve your problems and make you and your hair look better.
You'll date a lot.
You'll lose fat. Your libido will go way up. And we know it's not really like that. Of course, there is an effect, but we also have to be careful not to have a side effect that later on could even make things worse. And considering your goddesses, right? They're around 35, 45, already close to menopause, which varies a lot, right? It ranges from 45 to 55. It depends. There are women who go through it even earlier. Thinking about that, thinking before you do any intervention, because for us men, that's how I see it, okay? I have a better understanding of male hormones because it's actually much simpler, right? Because women have ovulation variations, right? So doing hormonal modulation in women is much more complicated. Men are simpler. We have testosterone that drops, but it drops in a more regular way. If it's low, you can check the dihydrotestosterone. If it's not decreasing, it's aromatizing. For men, it's easier.
You don't have a uterus, you don't bleed, you don't have breasts, and you don't get breast cancer.
Our symptoms of low testosterone are basically three actually. Hair loss because it's dropping too much, right? There's too much dihydrotestosterone. It causes hair loss. Impotence, right? It can be due to testosterone deficiency or even dihydrotestosterone and weight gain.
Yes.
That's not really associated with hormones. A lot of people think it's because of age or because of stress. It really can be. So the hormonal issue in men is more, I'll put this in quotes here. It's not really simple, just simpler. For women, it's more complicated. So when thinking about men, I always say that male hormonal modulation. The longer you put it off, using the hormone is better because you don't create resistance in the receptor. And when you really need that hormone, you'll have a health benefit. Okay? I'm not talking about aesthetics. I'm not talking about bodybuilders. I'm not talking about people who want to gain muscle mass. I'm not talking about athletes. I'm talking about health. And for women, so you already have a woman, let's say, in premenopause. How can you approach this before entering? You notice that it's not time yet to use hormones. What can you do as a hormone inducer? What can be done there for about 5 or 10 years? Exactly to try to balance things out like you mentioned, right? To delay menopause because that's healthier.
Absolutely. First, you have to understand the complaint, right? For example, in my office, I always have women saying, "Oh, doctor, I don't have sexual desire anymore. I don't have sexual desire anymore." Sometimes I even do it just because I have to keep my marriage, but I don't have an orgasm. And then they already come with the preconception that the problem with low sexual desire is because their testosterone is low. In fact, if we measure women's testosterone today, the testosterone will be at a lower level.
Women's know the human race, everyone. We're seeing alarming studies about how testosterone levels in men, and I've seen more research related to men with women. You're telling me it's actually curious too. And it's a generation, in fact, that's not dating anymore.
No, there isn't. You don't have the testosterone. But since they already.
It's not only testosterone. Explain it to everyone.
We even have a beautiful scientific study that he does with a really large sample size. He evaluates the main causes of low libido in men and women. Testosterone comes in 8th place.
Look at that.
So who's in first place? The very first cause of low libido? Stress. Who isn't stressed these days? Cell phones, right?
And cortisol. Even though testosterone is in 8th place, there's nothing testosterone likes less than high levels of cortisol. High cortisol, low testosterone. High insulin too, low testosterone.
And in second place, obesity.
Insulin resistance.
Insulin resistance, stress, sedentary lifestyle. So, answering your question, the first thing I say to my patient is, do you want to have sexual intercourse? Do you want to have quality sex? Are you exercising? No, I'm not. So the first point is.
And your dopamine goes way down too, right?
Oh, and another thing, this here, dopamine all the time, right? Yeah, people are addicted. So testosterone will also drop. So these are simple measures we can take that have a big impact. And another thing I really invest in, I talk about this a lot with my patients. Physical activity for women means weight training.
It's weight.
Wait. You have to work out, work your quadriceps. Squats, make those quadriceps grow. We're just joking, right? In a group I'm part of, which is Hormones Mentoring, it's about building a muscle bank. We have to build up muscle reserves because muscle loss is going to happen.
Sarcopenia. They're already saying it's as serious as obesity, as insulin resistance.
So we need to invest in this, right? Oh, I don't have time.
No, but you have to make time.
You have to make time, but then you work from Sunday to Sunday, 24 hours a day. No, you have a weekend. Do it on the weekend.
That's a lie. You have time to watch Netflix. You have time to watch silly things on TikTok. Everyone has a little bit of time. Yes, they do.
So I always suggest starting with lifestyle changes, right? Because they really make a difference. A woman who stops being sedentary, starts exercising, starts gaining muscle mass. Automatically, she boosts the production of testosterone, free testosterone.
And of dopamine, right?
And of dopamine.
Because especially the thing about orgasm has a lot to do with dopamine.
Yes, and not only that, it also improves circulation. If I improve circulation, more blood reaches the clitoris. If more blood reaches the clitoris, my orgasm is better. So there are several
more energy, more willingness.
Benefits, right? Supplementation, for example, B complex, vitamin B12, really improves testosterone production. So we have some strategies that we can use, and we don't necessarily go straight to testosterone replacement.
Perfect. Just remembering that we're talking about hormones for health, okay? Because someone might come here and say, oh, but my doctor prescribed me, I don't know, 300 of testosterone, right? To raise it to 300 in the case of a woman, or 500, I don't know. How much they use out there, that's how much they use. Not for bodybuilders, right?
To gain muscle mass, the doses are high.
There are people who use huge doses. We're not talking about that, okay? We're talking about women who will get a deep voice, who will talk with a rough voice.
Whose hair will fall out.
Whose clitoris will grow and later on will have libido problems because there will be axis blockage. There will be a series of problems. We're not talking about that. We're talking about hormonal modulation.
Exactly.
For health purposes.
And I'd like to take this opportunity to make a point, even as a warning. I don't know if you'll allow me.
Of course I allow it here. Everything's allowed.
It's actually a very interesting case that I had at my office. A patient who had been seeing me for a long time came in for a regular checkup. And I noticed that her upper limbs were stronger than usual. To me, more masculine.
Masculinized.
She was really simulating as if she were doing testosterone replacement, but it wasn't prescribed by me. So I asked, Fulana, are you using testosterone or any kind of anabolic hormone? No, doctor, I'm not using anything. Okay. At the follow-up appointment, she comes back and says, Doctor, I wanted, if you could, to take a look at a photo of my little girl's intimate area because a small lump has grown there. I took her to the pediatrician, but the pediatrician wasn't really sure what it was and so on. I saw the photo. Moral of the story, the husband, the man, was taking testosterone on the skin and testosterone replacement in very high doses.
A man is 10 times bigger.
And on the skin. The skin only absorbs 20% of that. So let's say if he was applying 100 milligrams, he was only absorbing 20. 80 was staying on the skin. He contaminated his wife because she slept on his arm, and the girl too. So this is a warning that after it happened, since she didn't know, nobody knew about this risk of cross-contamination, I realized how we also need to warn men who are doing hormone replacement.
And the opposite also happens, right? Your wife goes into menopause and you can get contaminated with progesterone and estrogen that your wife also applies to her skin. And estrogen is the same thing. It's a much higher dose for women than for men.
And I always warn there is a more vulnerable group which includes children, the elderly, and pets. But everyone is subject to contamination, right? When we're talking about a transdermal replacement on the skin, it's very important to be careful.
Some people say to put it behind the leg, right?
The recommendation for women is always from the waist down because of the risk of contaminating the breast. So everyone, I always tell my patients behind the knee, inside the thigh.
That's for both men and women, right?
These are safer areas. Or, oh, I don't want to go through that. The hormonal implant. Hormonal implant.
Let's talk about the hormonal implant. First of all, the hormonal implant has been a huge controversy recently. What is a hormonal implant? It's the so-called chip, which isn't actually a chip. It's an implant that you brought.
I'll get a bigger one so you can see.
And you have, look at that. And inside here, you have an implant that contains several things. It can have them here, right? It can have testosterone, it can have estrogen, it can have gestrinone, it can have a number of things. And then you implant it in the woman for a period of time.
This particular implant lasts for 6 months. It's an absorbable implant. What does that mean? You put it, it works like an Alka-Seltzer. It peaks and then gradually decreases. Some patients will have a shorter duration, for example, women who use antidepressants. They may have a shorter hormonal therapy because of metabolism issues and so on. Those who exercise a lot may also have a slightly shorter duration, 5 months for example. The advantage of this therapy compared to the gel on the skin is safety. I joke with my patients that, for example, during menopause, we replace estradiol and progesterone, and testosterone too. These are the 3 main hormones.
Although it's very common to increase testosterone during menopause.
Yes, it can happen, yes, but then the free testosterone doesn't go up.
The total goes up, it does, because sex hormone binding globulin goes up too.
The total testosterone goes up, but the free one, which is what?
It's the free one that matters. Do you know what's really interesting for releasing testosterone from sex hormone binding globulin? I didn't bring it here, fenugreek, but fenugreek is standardized dry extract. It has to have at least 300 milligrams of furostanol. What does furostanol do? It's there. 97% of testosterone gets bound to sex hormone binding globulin to monoglobulins there. It releases that testosterone. It doesn't produce more testosterone, but it releases it. It makes that testosterone available, which is what you said. It releases free testosterone.
Yes.
So it's a supplement I really like, fenugreek, exactly because it has this property. And then you take it further, the need for hormonal modulation. And it works. It's interesting for women. It works for women. Put it there in your...
You can give me a gift.
Put it there in your... This supplement is really cool, really cool. It's something that you use there in the pre for you to use. And later on, if you need it, then great, then you use it. It's that thing about the receptor I was talking about. The more you keep your receptor calm, the better. But regarding the implant, no problem. I wanted to ask you a question that I think many others have too. You're going to start a process of hormonal modulation, whether with testosterone or estrogen. Personally, I don't really like synthetic ones. It's a matter of,
But here it's only bioidentical.
yeah, I like bioidentical. I think it's more natural, even though not even bioidentical is 100% natural. But let's put it this way. Then you add it. Let's imagine, because hormones are like this, you add them, but they don't necessarily work the way we think they will.
Yes.
And then you added it for the first month. And let's imagine that, let's think about testosterone, okay? It's easier for us to think about it this way. Let's imagine that this testosterone in the form of an implant, it's reducing too much. So this person has a lot of 5-alpha reductase. He's reducing too much and producing a lot of dihydrotestosterone. And then you get the classic symptoms, right? Hair starts falling out, acne, and so on. How do you fix that? How do you correct it?
My clinical practice? Well, it depends. For example, if she has a lot of symptoms, a lot of acne, a lot of hair loss, excessive hair growth, I like to use spironolactone, so I prescribe spironolactone. Along with spironolactone, I also prescribe other supplements. I don't know if you've heard of them.
Saw palmetto.
Saw palmetto, beautiful.
It's a 5-alpha reductase blocker.
Of 5-alpha actricity.
Pumpkin seed oil, if I'm not mistaken.
And X-Nutrimente, the X-Nutrimente, it will also work as a 5-alpha blocker.
But you don't use finasteride, do you?
Not in women, unless she's experiencing very severe hair loss. Because if I start using finasteride after I stop, I cause a drop in testosterone.
Yeah, when finasteride came out for male hair loss, people started using it, right? And today you have a serious problem with people who use finasteride and are now infertile.
Yes, and we can't even think about infertility in women because it's teratogenic, right? Not teratogenic, but it can cause
It's in that risk group.
category X.
Saw palmetto is pretty cool, right? As a 5-alpha reductase inhibitor. I love it.
I love it.
So you make the correction there in the enzyme, and in the same way, if it's aromatizing. If it's aromatizing, because in women it's not that complicated. If it's aromatizing too much, you go in there, I don't know, with chrysin and block it.
Yes, exactly. How do I do the replacement for health, right? We don't do replacement.
It's easier, right?
It's much easier, it is. And usually,
Because when the guy takes the dose, the woman in this case, right, takes the dose. The guy too, right, takes a huge dose. Those inhibitors don't even make a dent.
not even a dent. Then you really have to use a medicated aromatase inhibitor. But I don't have that kind of problem. Of course, there will be one or another patient who will have a crisis.
You start with less and then increase it. Is that how it works?
Regarding,
The person who has never used it.
for example, replacement, the treatment is 100% personalized. So, for example, I have a patient who weighs 70 kilos, is 50 years old, and complains a lot about libido, low sexual desire. She has hot flashes, a symptom of menopause, and experiences all those symptoms. Hot flashes, irritability, memory loss, dry skin, and vaginal dryness are the main symptoms. I order a lab test. Through the lab test, it gives me a direction. What is her current hormonal production status? So in the case of testosterone, I'll teach people how I do it. But for example, if her total testosterone is below 50 and she has a lot of symptoms, I'll start her on about 50 milligrams of testosterone. This will vary from patient to patient.
And your clinical experience, you've already gained some, so you know how things will go. That's what you said, right? If it's decreasing, you have the tools to prevent it. If it's aromatizing as well,
And I'm very cautious with hormone therapy.
you have to be, right, Tatiane?
I start with high doses and I tell my patient that
Start with a little.
we're going to start with a little. Don't get your hopes up because you might not reach it.
The expectation you had.
I'm very, very conservative in that regard. There are colleagues of mine who will really use massive doses. Will it work? Yes, it will.
But what will it work for?
And another thing, if the lowest possible dose worked, improved symptoms, improved lab results, why increase it? It doesn't make sense.
Exactly. But let's imagine a hypothetical situation here. A patient comes in, doctor, I want to get really big. I came here to get huge like a centaur. I want the hormone that those Instagram women use. with those tree trunk legs. And it's not just the legs, they even have shoulders, right? Big, strong shoulders. So, what do you do with a patient like that?
Then I refer her.
There's a way, right? But I don't do it.
I don't do it. I don't do it. It's a commitment I made, like from the moment I started working with this hormonal part. It's actually quite an interesting field, thinking from the point of view of returns, right? There are people who look for this kind of therapy, but I didn't specialize in this area.
Which is aesthetics, right?
It's about promoting health. So it has happened once or twice that someone sought it for that purpose. I refer them. I actually have a colleague very close by who does this kind of follow-up. I refer them. It's not natural.
It's not natural. I always say, Tatiane, like this, I have no problem with people who do it. No.
Me neither. I respect it.
If you want to do it, fine. I wouldn't do it, okay? But if you want to do it, fine. Just be aware of the risks. And most importantly, look for someone who knows what they're doing.
Not only knows what they're doing, but can also resolve any issues.
No, because it's tricky, because you have to do cycles and it changes and it's a complicated thing. Even those who do everything right, I don't like it, because I always like to joke that hormones are like a symphony orchestra, right? So you're playing Rachmaninoff's third. If you just add a cello, just increase the cello, the music gets lost.
Yes.
So that's very complicated to do. All this, when it's subtle, if something's missing, nothing is better. And we'll get to the cancer issue in just a bit. I'm sure it's a concern that a lot of people have and that some doctors still insist on. And I understand why they insist on it. I'll explain why they do, but it's like a symphony. If you want to go up, then in the case of women, right? I always like to joke. Female hormones are progesterone and estrogen. Is there testosterone too? Yes, but female hormones are progesterone and estrogen.
Absolutely. In fact, if we replace estrogen, estradiol, which is the bioidentical one, it automatically improves testosterone.
And it's not always low either.
It's not always low. Sometimes, for example, during the transition to menopause, what happens? The ovary, it reduces the production of estradiol, which is the main female hormone. If I have a reduction in estradiol, the body will try to get estradiol from somewhere. One of the ways is by converting testosterone, which is being produced in the adrenal gland, through aromatase.
The adrenal gland boosts production, right?
It rises. In women, 25% of testosterone is produced by the adrenal gland, 25% by the ovary, and the remainder peripherally. So the body will find some way to get the hormone. If the ovary isn't producing it, it can convert testosterone into estradiol. So what will happen? Libido drops, energy drops, muscle mass can be compromised, poor memory. But if you replace the estradiol, you don't need to.
Then you already inhibit the feedback. Yeah, that's true. When you add estradiol, this feedback doesn't happen and testosterone goes back to normal.
It goes back to normal, so not always.
And it's not to, look, see here, you just said something interesting, because many times you get a test and you do a test, a quick look at the test, a shallow view of the test. This case is interesting. You saw that the testosterone is low. So what would be the logical thing to do, but not the right thing? Give her testosterone. No, because this testosterone is turning into estrogen because it's lacking.
Yes.
If you give estrogen, you get the same effect, because the estrogen will normalize and the testosterone will go up. So I say this a lot when it comes to testing various things. But hormones are a classic example, because a low testosterone level doesn't always mean, and this goes for both men and women, that you need to take testosterone. It might be getting reduced, it might be getting aromatized. How about luteinizing hormone? Is it normal? Is it giving the signal? How does that work? Primary hypogonadism, secondary, and so on. So you have to assess this exam issue in a more holistic way. Exactly. That example is amazing. I myself was making that mistake. No, you have to give estrogen.
If you replace estrogen, it's solved.
And then comes the controversy. What happens with the hormones? I wasn't even born at that time. There was a time in the 90s.
But we know.
Conjugated estrogens came out. It was a craze.
Equines.
Conjugated estrogens and medroxyprogesterone Medroxyprogesterone is still used today, two synthetic hormones. The conjugated estrogens came from the urine of pregnant mares. They were produced from the urine of pregnant mares, and it was a craze, Tatiane, it was a craze. Compounding pharmacy prescriptions at the time, half of the prescriptions that came in were for conjugated estrogen. Every woman
Was using it.
She was using conjugated estrogen and medroxyprogesterone. It was wonderful for menopause symptoms. It really helped. The hot flashes, it was amazing. Libido was great. 5 or 6 years later, there was a wave of breast cancer. It was something absurd. And then the professionals from that time who are still working today came up with something. The association got involved, saying it couldn't be used, that it caused cancer, risk of cancer, and so on. So many professionals who are still working today remember that. And then came that almost like a mantra: hormones cause cancer. In our case, as men, testosterone increases. The higher your testosterone, the greater your chance of prostate cancer. Which isn't true. In fact, testosterone actually protects against prostate cancer. Women, high estrogen increases the chance of breast cancer, ovarian cancer, and so on. First, is that true? I'm asking because sometimes people don't know and all that. Is that true? And how do you approach a patient who comes in with this fear, with this concern, and often even guided by someone else? My mentor told me not to do it. No. But how do you approach? How do you deal with this patient?
I still receive patients with this fear, especially those who are 55, 60 years old, who are from that time, and who went to another professional who discouraged them from undergoing hormone therapy. But, as you pointed out, this study, which was quite alarming at the time, was a study that used a synthetic hormone taken orally, extracted from a pregnant mare. Oops, we're humans, right? So we took a hormone that the conformity, right, the metabolic formation there isn't the same as in humans, and it was administered orally. But there's still a point about this study that few people talk about. It had some biases. One of them,
Like all studies have, right?
but this one in particular didn't take into account what we call the window of opportunity to start hormone therapy. We can only start hormone treatment up to 10 years after the last menstruation.
Ah, perfect. Perfect that you mentioned this. This is really important.
Yes. So, for example, if you stopped menstruating today at 48 years old, you have until you're 58, which is 10 years later, to start hormone replacement therapy. Are there exceptions? Of course there are. If the woman is an athlete, if she's in good health. Anyway, I won't get into that. But what we use as the window of opportunity is those 10 years. Why, Tati, does it have to be within those 10 years? Hormones, you mentioned this too. They work like a key in a lock. If I have several locks there to connect my hormone, it works. I entered menopause. I don't have hormones circulating anymore. What is the body going to understand?
The locks disappear.
Let's get rid of the lock. There's no need. Why? Why would we leave this here available? This happens over a period of 10 years. So in 10 years, your body gradually gets rid of the locks. If I give hormones to this woman, where will it connect? It won't go to the place it needs to go. It could go, for example, to your intestine, or it could go to your breast. It raises breast sensitivity and risk. So the big takeaway from the window of opportunity, which we really emphasize, is that we shouldn't lose this system.
Do it as soon as possible.
And do it as soon as possible. And then this particular study, which caused all the controversy about hormone therapy, did not use the window of opportunity as a criterion.
He included women of all ages.
Who wants to do hormone replacement? And it was done all over the world. Is the therapy done in Brazil? Was it the same as what was done in the United States? Was it the same as what was done in France?
The observational study has this problem.
And then we gathered. I say it was a very dark time because women lost the opportunity to have proper hormone replacement. Why do we keep insisting on this? Why do I encourage hormone replacement? Oh, is it because I want to have sex? Because I want to be seductive? I want to be... No. We recommend hormone replacement because I want to prevent osteoporosis, which is one of the main causes of death in women during menopause. I want to prevent cardiovascular disease. Women during menopause, she has more heart attacks than men because we lose estradiol's protective effect on the heart. I want to prevent Alzheimer's. Alzheimer's affects 3 out of every 2 women without hormone replacement therapy. It's a disease much more prevalent in women than in men. Here comes preventive medicine again, this preventive care. So when we suggest hormone replacement, I'm thinking about disease prevention strategies. Then this patient comes to my office. Tati, I haven't done hormone replacement until now because the doctor I used to see said it causes cancer.
No, usually she says, didn't allow me.
Didn't allow me, said that menopause is just like that it causes cancer.
It's because of your age. That one I hate.
You have to accept it, that's your condition.
I hate it's because of your age.
And then I use exactly those arguments. The first argument, we're doing hormone replacement for prevention purposes. Hormone replacement does not cause cancer, period. In fact, a scientific study will be published later this year by one of the most influential researchers in testosterone hormone therapy. And it seems,
Aside from the woman's cognitive issues.
but testosterone has a protective effect on the breasts. In fact, this study is going to come out and challenge several truths we used to believe about hormone therapy in women with breast cancer. So we are waiting for a scientific study that gives us more support to do hormone replacement. And then I use these arguments. The hormone is a bioidentical hormone. What does that mean? It has the same structure as the hormone I have inside my body. So by itself, your body already recognizes it as something natural, in quotes, something of your own. Second point, we are doing a replacement in ultra-low doses.
Starting with a little, right?
I don't do high doses. Third point, our main action is the prevention of the main disease that kills people worldwide, which is a heart attack.
Which is cardiovascular disease.
Which is cardiovascular disease. When we present these arguments, it's unlikely that the patient will be afraid because she understands that it's a health issue. And let's be honest too, a woman in menopause, when she's in classic menopause, irritable, hot flashes, dry vagina, having sexual intercourse with a dry vagina, my patients tell me, Tati, it feels like it's tearing inside, it burns. That's very uncomfortable. You don't have quality of life. So they say, no, I'm going to try this hormone replacement.
And it gets so much better.
A lot.
It gets so much better.
It's fantastic. I always say that I feel so fulfilled when I see the patient. She comes into my office with an expression. You can see that.
Even the skin gets better, right?
Not just the aesthetics, but the sadness, the depression, the melancholy, the phobia.
It gets more hydrated, right? It really gets better.
A lot.
Guys, hormones are amazing.
With caution.
Within physiological levels. Moacir, but I want to use it to get jacked. I want to use it to get ripped. Use it, just don't do 2 things. Don't do it with just anyone. Do it with someone who knows what they're doing. And for God's sake, don't go on Instagram saying that's creatine, right? That it's something else. You take it and say, oh, it's creatine. No, admit that you're taking it. Tatiane, today we have an epidemic of some deficiencies. And then women, not just women, men too, as they get older, have this problem. And I see this in classical therapeutics. It's addressed very little. So, for example, you have, today we have a very low level of vitamin D in the world population.
Yes.
Right? And yesterday I was even talking here with Dr. Juan Paulo. We get the test today. You open a test, that range, right? That's an average from the lab. So Tatiane, I've been observing this epidemic of deficiency in several nutrients, and it really is an epidemic, okay? And the most classic example is vitamin D. But there are others, and I see it as a problem, not just because it's low, but because people don't get sunlight anymore, right? And there's very little in food. You look at a test today, and there's the average. That test is an average from the lab, it's there. Vitamin D above 20 is great. It's not, it's very low. Most patients just look at the test, accept it, and don't even consult the doctor. They see it's 25, great, and move on. I'm great, and that goes for a lot of things, right? It goes for B12. B12, I joked with João Paulo here yesterday that for me, B12 has to be below 900. He said, for me, it has to be over 1200. I said over 900. He told me it has to be above 1200. Yeah, you're just going up, and you say that above 300 is great, but we know it's not. So today you have, besides this deficiency of these nutrients, B12 because of the intrinsic factor, since acidity decreases with age and then it doesn't activate the intrinsic factor. And the diet isn't that great either. People don't get sunlight. Coenzyme Q10 production decreases over time. And if the person takes statins, it's even worse because statins lower coenzyme levels even more. So we have this deficiency, a deficiency of some nutrients, and some doctors. And then going back to what you said, which I found very interesting, that some people call it integrative medicine and others call it classical medicine. I talked to both sides. The people from classical medicine call integrative medicine alternative, like that's alternative medicine. It almost sounds like witchcraft. And the people from integrative medicine say, no, that's just medicine for pill pushers. So one side ends up disqualifying the other. But I noticed that the more classical folks, they see this kind of replacement in a sort of, no, that doesn't do anything. Oh no, if you take that, you're just going to have expensive pee, right? Obviously, not everything is for everyone. You're not going to take, even though I take an arsenal, I also take the arsenal. And sometimes even financially, that's not feasible. But you have some that I mentioned, some here that are classics. You have an epidemic of low B12, which can even be mistaken for depression, memory problems, cognitive issues, a severe deficiency of D, which can cause the problem that you must face a lot, which is osteoporosis. There are a lot of people giving calcium to everyone, but it doesn't help. The body won't absorb this calcium. It goes to the arteries. How do you, in the case of your patients, how do you approach this issue? Do you evaluate? Do you supplement orally? Do you like to use parenteral? Many times it's necessary because the levels are too low. Antioxidant. And how do you see it? Or do you think it's not necessary? You can also say, I agree, it's not very useful. And why do you think this happens? Why is a medication so easily prescribed? No, a medication, and you take, for example, any fever medication out there, which is even banned in Europe, in the United States, and it's sold, it's on sale at the pharmacy, and they put so much fear. Don't take magnesium, don't take creatine, it'll ruin your kidneys. Where does that come from?
I think it's a lack of information, you know?
Really?
For example, let me bring it to my clinical practice. I work a lot with women with endometriosis. It's one of my specialties, right? It's one of my specialties, which is the clinical and medicinal treatment of women with endometriosis. Endometriosis is an inflammatory disease, so I need anti-inflammatory strategies to get a good response, right? So that the patient can have quality of life. One of the strategies we use, and it's not just me saying this, it's in the guidelines, it's discussed at scientific conferences. It's vitamin D in higher doses,
Which is an inflammatory modulator.
So if I'm dealing with a woman with a case of endometriosis or adenomyosis or premenstrual syndrome, which are all estrogen-independent diseases, and she shows me a test with a vitamin D level of 20, I'm honest with her. I say, look, this test result of yours doesn't correspond to an ideal value for someone with endometriosis. We need to increase your vitamin D. It's part of our treatment to make sure you have that we optimize all the possibilities so you can have a better response to your treatment. So I always guide my patients, even with the tests. I write in front. Ideal vitamin D greater than 60. Vitamin B12 greater than 700.
So do you prefer to do the injectable or do you go with the oral?
It depends. For example, if the patient needs a quick response, vitamin B12 200,
Very low.
there's no way.
Then you have to go with injectables.
Use injectables. And here's another point I really like to emphasize. There are vitamins and there are vitamins.
Perfect.
The ideal is methylated vitamin B12.
Methylcobalamin, which is also a methyl donor. That will help. In fact, they're at the start of our conversation when we discussed genes. One of the ways to do epigenetics is to methylate this gene. So without a methyl donor, you even increase the chance of this gene being expressed. And it also lowers your homocysteine, by the way.
And it reduces the risk of cardiovascular diseases, thrombosis, and so on. So it's like a mechanism. Our body is...
There's so much cyanocobalamin on the market. It's unbelievable.
And 30% of women won't convert it. 30% of women don't. 30% of the world population doesn't convert cyanocobalamin into methylcobalamin. So in that case, you're just throwing money away. So I advise patients who have the possibility to use the methylated form. In the office, we work with this treatment with methylcobalamin. The response is very fast. The patient gets a more satisfactory result. And I joke that I gave methylcobalamin to my father. My father, just to give you some context, is an elderly man, but very virile.
He's very strong, right?
He had low vitamin B12. I said, Dad, let's do an injection. You'll respond well to it.
It's going to give you a boost.
I gave him an intramuscular injection. He said, my daughter, I almost got in the car, went to Belo Horizonte and came back. Because vitamin B12?
Low B12 gives you a blues, right? It makes you sad. A lot of people confuse it with depression, right?
Yes, and B12 is essential for the muscles, so there's no way you can exercise regularly and keep your vitamin B12 low. Your performance in physical activity goes down. There's no way around it.
Perfect. And I just had a checkup. It was a little low. I stopped because I was taking a supplement. Actually, I take too many supplements, Tatiane? And then sometimes I have to stop with one and continue with the other. I take a supplement that is methylcobalamin, methylfolate, and pyridoxal 5-phosphate for...
And the methylator?
Yeah, to lower homocysteine, right? This compound is to bring homocysteine way down. And then later on, I went to take a test and my B12 was at 1800. I said, no, I have to...
Hold back a little.
Then I went to check my B12, and it was really low. I said, my God. So I had to go back to taking the supplement.
Because you use up a lot. So you have to replace it. That's how I do it. And I don't see any resistance from my patients.
No, I don't see it with the patients. I see a lot of professionals disqualifying it.
Yeah, but I think it's because they don't understand it deeply. For example, I see a lot of professionals disqualifying the injectable compared to the oral. Let's go.
It's the same thing.
It's the same thing. The only thing that changes is the bioavailability.
It's just faster.
Faster and more effective, right? The pharmacokinetics, the pharmacodynamics of the medicine.
Even more so if it's a substance that gets stored, right? Which is the case with B12.
The case with vitamin D.
Yes, it's more practical, right?
Much more.
And for that patient who isn't very disciplined with capsules, who already takes too many, it's easier.
It's a strategy I really like to use in my office too. Giving intramuscular injections, for example, B12D, even coenzyme Q10 itself, to give a boost and make the patient feel energized. And I do the maintenance orally. So I like this strategy. We do.
If it's too low, you normalize it.
And then you keep it there for another 60, 90.
That's really the ideal strategy.
I really like it. Coenzyme Q10, I love it, especially for people who use statins.
For those who take statins, guys, if you take statins, the statins are medication to lower cholesterol, which most of the time you wouldn't even need to take, right? I had a cholesterol test. I was talking to João here yesterday. My cholesterol is 247 high. So if I take it to any doctor, well, saying any doctor is an exaggeration. Like if I take it to a more traditional doctor, he will definitely prescribe statins. But my triglycerides are 88. My high density lipoprotein is 75 or 75, if I'm not mistaken. That ratio came out to 1.8. My ApoA, ApoB is okay. The inflammatory markers are way down. So let's imagine that I take statins, right? I'll get scared. No. You're going to have a heart attack if you don't take statins. Then you start feeling body aches, memory problems. You go to another doctor, take medication for the pain. Then your stomach hurts. You go to another doctor, take omeprazole. Then the omeprazole already makes things worse. The intrinsic factor no longer absorbs B12 the way it should. Depression starts to set in. Then I go and take a sertraline or something like that. Now I'm already taking 6 medications because of the first one, which I didn't even need. This happens a lot too, right?
A lot.
Do many patients bring a shoebox of medication?
I used to get more. I don't know if it's because women are more tuned into their health, right? They already come in like, look, I don't want to take a lot of medication. I like your approach that you work with nutraceuticals, supplements.
But do you take it out if that's the case? How do you do it?
That depends. It's complicated, right? For example, women in menopause, something very interesting happens. We start to accumulate cholesterol. That's physiological.
Accumulate, or is the total cholesterol high?
That's right. Sorry. Exactly. The total cholesterol tends to go up. That's physiological.
But does high density lipoprotein go up too?
No, high density lipoprotein doesn't go up. Low density lipoprotein usually goes up. Why? The body wants hormones. So one of the places where hormones are produced is in fat. If I raise cholesterol, I cause a buildup of fat, especially in the abdominal area of this woman, because the idea is to extract from that fat the hormone that the body needs. So it's natural in a lab test for a woman who is 50 or over 50 years old to see an increase in total cholesterol. I don't use statins. What do I do? The markers, ApoA, ApoB. In some cases, I even request an oxidized low-density lipoprotein. I ask for a carotid Doppler. Is there fat here in this carotid? Yes. Is it stable? No, it's not. So we do a screening, a look,
See if it's inflamed?
a broader look at her health, and then we assess whether cholesterol comes into play.
If that's the case, it comes into play, no problem.
No problem. If there's a need, if there's a risk of cardiovascular disease. Yes, but I really like berberine for cholesterol.
It's amazing.
And inositol is also very good.
Inositol hexanicotinate is amazing.
Exactly. And the rice, the red rice.
Red rice. It's an inhibitor. Red rice is interesting because statin inhibits 3-hydroxy-3-methylglutaryl, coenzyme A reductase, which enters the mevalonate pathway there and produces cholesterol. Red rice? It's an 3-hydroxy-3-methylglutaryl, coenzyme A reductase inhibitor, but interestingly, it doesn't seem to be such a selective inhibitor. It inhibits cholesterol production, and it seems like it spares that little thing. Don't ask me why. I had a biochemistry professor who used to say, man, the problem lies in the perfect reaction. When you see a perfect reaction where everything fits, where everything is perfect, that you observe in vivo, and it doesn't happen, you get really frustrated. So when you inhibit 3-hydroxy-3-methylglutaryl, coenzyme A reductase, you should have an inhibition not only of cholesterol, but also of coenzyme Q10. It apparently doesn't change even though it inhibits the mevalonate pathway. Red rice is interesting. There's one called, I can't remember the name, it's bergamot extract. It's called, what's its name again, guys? I won't remember. No, there are so many supplements, but it's a bergamot extract. It's a special kind of bergamot they have in Italy. And it doesn't work through the mevalonate pathway. It has another pathway that it inhibits. That small, dense, and potentially oxidized low-density lipoprotein, which is the tricky one. It's amazing. But it's very expensive.
Usually these prescriptions are more expensive.
Red yeast is cheap. Hexanicotinate is cheap. Berberine is so-so.
But the benefits of berberine are so many.
It's because berberine doesn't just work. It works positively on the lipid profile and also helps with insulin resistance. So, the guy who's actually diabetic, he really has to, I take berberine. I've been taking it for 51, right?
And the results are very interesting. Very. Of course, we have to be cautious, right? I don't do anything without, for example, a cardiologist's approval. I have a patient who has lupus and rheumatoid arthritis, and then she went into menopause. She wants to do hormone replacement. We have to be very cautious. The rheumatologist is working with me as well, so it's something, there's no one-size-fits-all solution.
No, that's why, Tatiane, this approach, The term integrative, you use the term
Personalized medicine.
personalized. This personalized approach is real medicine, right? Because if you take Juan Paulo, I'm saying Juan Paulo, guys, because he's a mutual friend of ours that she knows. We had a chat here yesterday. He said that he went into cardiology and went to the hospital. And there, by the third month, he was completely frustrated because his prescription was always the same. It was an antihypertensive, a medication for cholesterol, and that was it. I don't know if he prescribed a diuretic, but he said all his prescriptions were the same. Oh no, baby aspirin. He said the prescription was always the same, baby aspirin, an antihypertensive, and a statin. And he started noticing and said, man, I don't want to do this. Why is every patient treated the same?
No, right?
It doesn't make sense. And why? Why is this guy hypertensive? Why is this guy hypertensive? It's not your area, but there are reasons too, right? Why is this guy hypertensive? Is it excess weight? How is it? This guy's catecholamines, is he stressed? His cortisol is high, right? So that's exactly it. This personalized approach, which is very common in the East, right? In the East, especially in Chinese medicine, they have this perspective. It's the liver, it's the heart, it's the intestine. No, how is the patient doing? How is he doing? Which is what I think is starting to come here, right? It's about seeing this patient as a whole. I mean, is this guy depressed? Isn't the problem in the intestine? Maybe his intestine is messed up and not producing serotonin.
Exactly. Maybe it's not a B12 deficiency.
Maybe I'm not confusing it with a B12 deficiency, the coenzyme itself. When the coenzyme itself is missing,
Women who use, for example, combined oral contraceptives, the pills have a much higher chance of B12 deficiency. And one of the side effects of the pill is depression. There isn't a relationship, not a direct one, right? But there's a strong connection between using the pill and a reduction in B12, which lowers serotonin, which can, for example, lead to a depressive episode. You have to have this comprehensive perspective, right?
it's the holistic view that, thank God, I'm noticing. I don't know if you are too. The younger generation already has this perspective, and if they don't, in 5 or 10 years, they'll be out of the market, okay?
Yes, for sure.
Because the patient is already on the internet too, see?
He already knows.
He already comes to the office knowing, prescribe statin. Why aren't you prescribing the statin? Oh, my triglycerides are low. Then the doctor is like, where did you get that from?
Aren't you going to prescribe me some vitamin D? My vitamin D isn't good.
Your vitamin D is fine, your vitamin D, but it's 25. No, it's fine. Okay, doctor?
That's it.
It's not like that, okay?
I think it's wonderful.
I think so too.
Because you have the opportunity to treat a patient who wants to be healthy, and that's difficult.
He doesn't actually want to get sick.
He doesn't want to get sick. He wants to live. He wants to live with quality. And there's an expectation that we'll become centenarians.
No, I'm going to live to be 120 years old.
I'm sure of it.
I've already decided, it's already set, and I want to live to be 120 years old. I'm going to travel alone until I'm 110. I think at 110, it's time to relax, to take a break, go to the edge of a beach and just stay there, Over the past decade, I haven't wanted much either.
I've already lived a lot.
Tatiana, what else? What can we talk about? Polycystic ovary syndrome. What do you see a lot in your office? What do you think is the biggest problem for women around 35 and up, 40 and up?
Thinking about polycystic ovary syndrome?
No, what do you see the most there? What are the main complaints? Of course, menopause itself is already a complaint, right? But it's a physiological process. It's going to happen. You don't have to have the symptoms, but it's going to happen to everyone. But what have you noticed that has increased in a scary way in the last, 10 years, 5 years that you've been working?
Yeah. I see that there's a pattern of complaints, okay? There are especially cognitive complaints, memory, focus. I'm very distracted, my memory is bad, my thinking is slow. Complaints related to sexual desire as well, a lot. So, oh doctor, I don't feel like having sex, or I do it, but I don't take the initiative. and excess weight. So women are complaining about the difficulty in losing weight, about an accumulation of fat. And it's the disease of the century, right? We've never had so many obese people in Brazil's history, right? So this overweight and obesity, which is a disease like we have today. So I would say I would classify these as the three main complaints: memory, libido, and I'm not at an appropriate weight. And especially when thinking about weight, excess weight, being overweight, it causes metabolic changes.
The worst thing that exists is the process of metabolic syndrome. It throws your whole body out of balance. Inflammatory markers go way up, and it's a nasty thing, isn't it? Because you eat junk, right? You mainly eat sugar, refined carbohydrates, then you get an increase in insulin. This insulin will cause insulin resistance, which means you have to produce more insulin because the receptor is already resistant, so you produce more insulin.
It makes you hungrier.
Yeah, then it makes you hungrier. Then I joked, I think it was yesterday. The worst thing you can do for a diabetic is call them pre-diabetic. I dislike that term. They already have metabolic syndrome. Then you prescribe, the worst thing you can do is prescribe metformin and glycoside for them, because those medications won't solve their problem, they won't cure it, and they won't reverse it. And in their mind, oh, I'm taking a medication.
I'm fine, I'm covered.
I'm going to keep letting loose. And this logic is perverse. Insulin goes up, insulin gets higher and higher, and the pancreas collapses. Then you actually enter a process of diabetes, and then you have to take insulin to replace it, which is what made you sick in the first place. And this will increase fat. This fat will aromatize. Your testosterone will go way down. Your growth hormone will go way down. Your energy will go way down. It's such a vicious thing, so vicious that how have you observed this eating issue, especially with your patients? Are they more aware that junk food has no nutrients and will only make them gain weight? It's still hard for you to turn to her and say, look, a slice of bread has no nutrients. I love it. That's fine, but it has no nutrients.
Uh-huh. I think there's still a certain difficulty in understanding what is nutritious, who is nourishing you.
What is a nutrient, really, right?
The food industry put it in our heads that this is whole grain. Wow, so I can eat it. But I'm eating whole wheat bread.
7 grains, 25 grains, 48 grains.
Refined sugar, right?
Demerara sugar.
Demerara. So I think these terms have made people really confused about what's healthy and what's not healthy. And so there's a very educational role that I play in my office. But for example, I can't explain to all the...
You also do this on social media, right? You have a big channel, a powerful way to communicate this.
Exactly. But it's a little bit of hard work. I have to speak up, but you also have to speak up. And other people who are more active on social media, it's important for them to speak up because people don't know what is nutritious. Oh no, but I drink coffee without sugar.
Then what do they eat? Bread, cookies?
Bread, stuffed cookies. So there are some little food sins in quotes. I don't know if I can use that term if it's the most appropriate, but it does make a difference in the diet. Not just in the diet, but also in insulin resistance. Polycystic ovary syndrome, which is a gynecological disease that leads to infertility, increases the risk of this woman developing diabetes, high blood pressure, metabolic syndrome. In the future, one of the causes of polycystic ovary syndrome is increased insulin resistance, which started where? With poor diet and most likely in childhood.
And it will make your insulin resistance worse. It's going to mess up your gut, right? Because you stuffed cookies, that you gave the perfect example. What are stuffed cookies? Hydrogenated oil with starch, then they put enriched flour. They have the nerve to say it's enriched flour, right? Hydrogenated oil, enriched flour, and salt, which is a flavor enhancer. Sugar and salt, the flavor enhancers, right? And they call that food, and then you end up ingesting that in your intestine. The good bacteria don't even know what that is, right? I mean, hydrogenated oil is like a Frankenstein sugar. Only the bad bacteria like it. Wheat flour is sugar just the same. It's a carbohydrate. So you're going to have an insulin spike, you're going to mess up your gut, and you're going to raise your inflammatory markers. Interleukin 6 will go up, tumor necrosis factor, alpha will be high, everything will be high. You can measure it, it's all high. In other words, and that's what we ended up not talking about here. The main cause of most chronic degenerative diseases, which are all long-term, is inflammation. If there's inflammation, Alzheimer's comes, cancer comes, right? Arthritis, arthrosis. Most chronic degenerative diseases come from this inflammation.
And often it's related to diet, it's the lifestyle.
It has to begin there, right, Tatiane? With nutrition.
Yes, it does.
There's no supplement, no medication, no implant.
There's no quick way, right? You need to do your homework first. And epigenetics really emphasizes the importance of pregnant women having prenatal care, making it as healthy as possible, because what a woman eats directly influences the health. For example, the fertility of the eggs of that little girl who is about to be born. So it's important for those who want to prepare to be a mother, right? And so on. To have this dietary care and to teach children from a young age what nutritious food is. Oh, I don't know. Look for a nutritionist or ChatGPT, right? Artificial intelligence is here to help.
But we go back and forth too, right? Tatiane, because I've been noticing, I don't know if you've seen it, but there's been a growth of some nutritionists, especially on TikTok. I watch TikTok because I have TikTok. You have it too. So we post some things there and some things appear for us, right? Some nutritionists, even young ones, making jokes, doing some funny stuff. No problem with that, but they're only focusing on the calorie issue.
Yes.
Swap this for that. Yeah, the guy is just swapping one junk food for another. There was a guy who had the nerve to say that soybean oil, what's better? Olive oil. Look at that. No olive oil or soybean oil. They're both vegetable oils. Well, that's fine so far. They're both vegetable oils and basically have the same calories. I mean, what matters is the calories. But since olive oil is really expensive, go with soybean oil. Look at that. And it's a guy who has millions of followers.
Look how dangerous that is.
Look how dangerous that is. So, a nutritionist who has millions of followers and does things in a more playful, funnier way.
And they have an audience, right?
They have an audience, right? And then comparing, oh, you switch between butter and margarine. You were already defending margarine.
It's complicated.
Margarine is an esterified thing, completely artificial. Because of saturated fat. That you don't even know what saturated fat is, okay? First of all, there are several types of saturated fat. There's long chain, there's medium chain, you don't even know. And then margarine is supposed to be better. How can something artificial be good if your body can't recognize it? So sometimes you said, look for a nutritionist. There are times when I'm afraid because who is this guy going to end up with too? So it's what we were talking about at the beginning, right? Guys, nutrition is where it all starts, right? This whole conversation we're having here is the result. If you eat right, health follows. That's what you said, right? Unwrap less and peel more.
Peel more.
I'll go with the simplest, which is plant and animal. Or you can go to the supermarket. It's the farmer's market and the butcher shop. Everything you find at the farmer's market and the butcher shop, you can have. Anything outside of that. It's not forbidden, but you should avoid it.
Avoid. You don't have to be extreme, but a big part of women's diseases are related to the wrong diet. What is the wrong diet? If we could generalize too much sugar, too many carbs, especially those from white flour, refined ones, and a sedentary lifestyle, there's nothing else, there's nothing new to invent.
And it's simple, right? And I hear a lot. But what am I going to eat? I'm going to starve. Well, man, I don't eat any of that and I'm still alive.
Me neither.
I'm alive.
And so, from the moment I changed the way I deal with food, today I have all my meals nicely organized. I understand what's good for my body. I know there are foods I just can't eat. For example, garlic is extremely uncomfortable and indigestible for me.
I love it.
Yeah, I can't. Passion fruit, for example, gives me such a bad migraine that I have to go to the hospital to get medicine. So I'm aware of that, which foods cause me some reaction or not. And just like that, I'm also aware of what is good for me, and I choose to consume those things.
Also, for anyone listening who thinks it's impossible, but how could I live without this or that? Consider this. After you stop eating processed food, then, after a while, you make up your mind. Guys, it's been 10 years since I last ate it, and when I do, it tastes like plastic.
Yes, and it feels awful.
It tastes like plastic. It tastes like nothing. It has no flavor.
Exactly.
It's something totally. These Cheetos, I don't even know if I can say the brand. These chips to me taste like nothing. They taste like plastic.
Yes.
Recently, I went to have a Coca Cola. I missed my flight to Brasilia and had to take the bus instead. We stopped and I saw a beautiful moldy Coke. I drank it a lot as a kid. I said, guys, it's been over 10 years since I had a Coke. It was actually more than 15 years. Let me have one here. I drank half a bottle, but it was too sweet. I couldn't handle it.
It's funny, you mentioned sweet things like coffee. I only drink coffee without sugar. Even if it's espresso, that's already a habit for me.
Espresso is the one that tastes good without sugar?
That's something I've been doing for a long time. If someone offers me coffee with sugar,
I can't drink it.
I don't drink it because my mouth, my taste buds, I say, no, I can't taste it. I can't get the aroma, from the bean, which is so delicious.
That's it. So it's not that complicated. You adapt, you get used to it. And if you go through, coffee is a good example. If you can drink coffee without sugar for 15, 20 days, stay strong. After 20 days, you won't go back to drinking coffee with sugar.
You won't go back. Also, you get picky about beans and won't drink just anything.
You become picky.
Uh-huh.
I bought a machine at home that grinds the beans. It grinds the beans and makes espresso right there on the spot. Pretty cool. And then you start getting picky about coffee too. It's not just any coffee. It has to be ground. You learn to taste the flavor of the coffee.
Yes.
You learn. You didn't notice it before. Why? Because before you were eating sugar.
You were masking it.
You were masking the taste of the coffee.
That goes for all foods.
All foods have a flavor, and that's what I always say. The two cheapest flavor enhancers are sugar and salt. If you add sugar and salt to any food, it tastes good because you'll only taste the sugar mixed with salt.
Yes.
That's why you consume so much sodium daily. The issue isn't salt itself, but sodium in processed foods.
Yes.
Because isn't that right? Tatiane, thank you very much. It was a pleasure talking to you. We've talked several times before, but here on the podcast, come back more often. I'm sure the goddesses loved it.
Goddesses who listen to me.
Follow Tatiane, okay? Tatiane's Instagram.
Dr. Tatiane Nacif at Dr. Tatiane Nacif.
And Dr. Altogether.
Dira. Tatiane.
Tatiane with an E.
Nacif.
Nacif, silent F.
Silent F.
Put it there, guys, on the banner. Tatiane's Instagram. Do you have TikTok?
Yes, it's the same.
Same thing. TikTok, same thing. Follow Tatiane. I don't know if you'll be able to get an appointment with her. Everyone I bring here, guys, has a busy schedule, right? But try there, okay? On Instagram, there's a place to book, right? Where you can...
There's a link that goes straight to my team. And online appointments, we do them online.
Oh, you do it online? That's easier.
There are people from all over the world.
Really?
Yeah, it's possible, right?
Yeah, today it's possible.
Medicine, right? The strategies we have, and we can see patients remotely, not in person. But being in person makes a difference, right?
No, it's completely different.
In my appointments, we do a bioimpedance assessment to check body composition.
Ah, perfect.
These are data that add more information there to my anamnesis. It makes a difference.
No, it makes a total difference. So follow Tatiane and follow me on my social media, okay? There are people who are watching me on YouTube and not following me on Instagram. There are people who follow me on Instagram, aren't on YouTube. Saúdecast is there on YouTube. There will be a channel just for Saúdecast, but for now, we're going to leave it on my channel. So don't miss it every Thursday. I'm going to bring here the biggest health experts in Brazil. We're going to talk about cardiology. We're going to talk about hormones. We're going to talk about supplements. We're going to talk about everything. So you, just like us, can also live to be 120 years old.
I don't think I'll reach 120.
You will. Technology is advancing a lot. With the care and technology that's coming out, 120 years will be the 120 generation, especially you, since you're younger than me. Thanks again, Tatiane. It was a pleasure. Visit more often, okay?
Count on me.
Come back more often, my friends. It was a pleasure. A big hug. Don't miss our next episodes here on Sootcast, and until our next meeting, see you then.